You want to test? All good?
Testing.
Okay, cool. Awesome.
Testing.
Welcome, everyone, to the XR in Healthcare sessions, unlike the talks that we typically have. And today we are actually going to have a different versions of a panel. And today we're very honored to be joining with an incredible group of leaders working across clinical care, medical education, simulation, and innovation. Their backgrounds span hospital systems, nursing, informatics, research, and immersive design. And together, they bring a very powerful perspective on how XR is shaping the future of healthcare. And for today, we have our four-time speaker and very great partner and sponsors, AMXRA, Dr. Hanping Mark Zhang, president of American Medical Extended Reality Association. Dr. Zhang has held leadership roles across digital innovation, clinical informatics, and medical education, including the Brigham and Women's Hospital, Dana-Farber, and the Harvard Medical School. He's also a founder and co-founder of multiple healthcare innovation initiatives, including the Journal of Medical Extended Reality, and has been a major force in advancing the medical XR community nationwide. And with that, I'd like to hand it over to Mark to lead today's session.
Thank you, Jenny, and thank you all for attending Harvard XR. First of all, I just want to just give a huge round of applause to Jenny and the organizers because they've really done it again. Congratulations. We're all just so proud and thrilled to be a part of this organization and this event. You know, I'm Mark Zhang. I'm the president and founder of the American Medical Extended Reality Association. We are the medical society dedicated to advancing the field of medical XR. And we're a nonprofit. We've been around for a little over 3 years. And we have kind of three major missions. Number one is to build the community for MedXR. And we're doing that through doing things like sponsoring events like Harvard XR and others, and also sponsoring some of our attendees coming to these events. We do monthly meetings in the AMXRA space. And we also advance the science of medical extended reality because it's a fairly burgeoning field. We're really trying to legitimize this field of medicine. And how we're doing that is we started the very first journal dedicated to medical XR about 2 years ago. So Journal of Medical Extended Reality, it's open access, published through our partners at SAGE, and it is and continues to be the premier place to publish medical extended reality peer-reviewed research. It is really my pleasure to kind of MC this panel with my illustrious AMXRA members who also are leaders in their own rights in XR. And without further ado, I think we should just do a quick round of intros. So Dr. Jacobson, after you.
Hello. Is this thing on? Yeah. I'm the XR lead at Immersive Design Systems. That is a working group inside Boston Children's Hospital. We are part of the support organization. So we're alongside the IT people, the janitors, the training people. We support the work in the different medical departments throughout the hospital. And our thing is systems analysis, human factors, and simulation-based training. And I am the older half of the XR team there. And for medical training simulation, XR can do some things that other modes can't, but is fundamentally very similar. I'll talk about that later.
Hi, I'm Amanda McIntyre. I'm a registered nurse at Brigham and Women's Hospital. I work in oncology. I have come to this place from a very unique background. I actually have a master's degree in fine arts. I taught art level college for a while. I then kind of segued somehow into being on founding teams of venture capital biotech companies, and then I got sick. And after I got sick, I really thought long and hard about what I wanted to do with the rest of my life because it was quite a thing. and I ended up deciding on nursing. So at 47 years old, I went back to school and I took all the math and sciences that I never took, got my nursing degree, got my job at Brigham that I wanted, working with oncology patients, see my oncologist all the time at the hospital. And now I am about to finish up my doctorate because I discovered extended reality. And I am here today because I truly believe that it is a technology that will help patients.
Hi, everyone. My name is Min. Really excited to be part of this panel and being invited back to Harvard XR. And again, congratulations to the Harvard XR organizers, Jenny and their entire team, for putting this together. I'm a practicing neuroradiologist at Brigham Women's Hospital, faculty of Harvard Medical School. Also one of the founding team and members at AMXRA, which again is, I think everyone should look into. It's really a leading medical organization, nonprofit, for advancing XR technology in healthcare. I'm also the Director of Research and Innovation at the Mass General Brigham MXR Lab. It's one of the first research lab, hospital-based, that's conducting validation, implementation research in XR. And outside of that, I've founded a couple medical startups in digital health and medical imaging space, and I'm a venture partner at a VC fund.
So as you can see, we have a pretty rock star panel here. And I want to make sure that I'm watching time because I think I have questions, I will ask questions, but I think it's going to be super valuable for the audience to be able to ask this panel questions about MedXR. But why don't we get some grounding, just origin stories. And maybe I'll start very quickly. I got into MedXR about 6 years ago. And actually, this is the segue, is one of the first groups we looked at. I was doing digital innovation work at Brigham and Women's at the time. We looked at our colleagues at Boston Children's, and they were like, oh, we've been doing this for years. So I see Dr. Jacobson as an OG in this space. So how did you all get into this wild world of medical extended reality? Jeff?
Well, back in the Jurassic period, in 1990, I was tired of hacking code for Honeywell, and I went looking for my muse. I decided I wanted to get into virtual reality, which had been around for 20, 25 years before that, starting with the flight simulators. And the choices were go into academia or the military. So I went for a PhD because it takes longer, so I could drag it out, which is exactly what I did. I did research on human factors. I did a lot of my own programming through the 90s, got into cultural history and heritage, but my degree is in cognitive science with a focus on how people process information and solve problems, with VR being the primary tool. And then a couple of failed businesses, academic success, but I'm not a Kirk, I'm a Scotty, and I'm good with that. So I got my job at Children's Hospital because at the time, XR was really hot, and the headsets were finally affordable. Oh yeah, I didn't mention, I got into VR thinking in 10 years this will be big, right? So I had to wait 25. But at the time I hired on, everybody had 1 or 2 years experience, except for a few thousand old creatures like me. So anyway, I'm here at Children's. I work with the team that creates simulation-based training for medical. I work with the clinical educators. 99% of what we do is for training nurses, and I am in awe of these people. I could not do that job And I'm just honored to be there helping them.
Now, Amanda, your journey to being here and researching XR is a pretty incredible kind of pathway. So I just want to learn more about kind of how you got here and your interest in XR. Like what got you into XR?
Okay, so I was working on the Dana-Farber inpatient hospital units. It was Christmas Eve. I had a patient that I had admitted like 3 weeks before. She had walked in, she was talking, she was energetic. And over the 3 weeks, she had just deteriorated to the point where she didn't want to have a conversation. She didn't want to engage with the television. She didn't want to read a book. She didn't want to do anything. She was just despondent and kind of staring at the wall and no lights on. It was just, it was hard. And I was frustrated. And the thought that I had was, she needs to get out of this room. When I was a patient, I think I was hospitalized a total of 80 to 90 days. So I know how it feels to be trapped in those four walls. And that was my thought. And of course, I just was like, I just want to take her to the beach because that's my happy place. So I kept thinking about this, and I was driving home, and I live on the South Shore of Boston, and so I get on Route 3, and there's a Best Buy on the side of the road. And I look at that sign, and it was like this light bulb went off in my head, and I said, wait a minute, can't I take the beach to her? And that is what started this whole thing that I've been doing. And I think it's, my kind of unique background that made me see the potential in it. At the end of the day, I'm a very practical person. And I am dog-headedly determined to bring this to patients because I truly believe that it will help. I think it would have helped me. And that's like a beacon, And so that's kind of how I found it.
So you really came from it, from trying to solve a problem that you saw in one of your patients, but also clearly a lived-in problem that you had.
Absolutely. My nickname is Mandy McIver. MacGyver was my favorite show growing up. And I think at the end of the day, all of the things that I have done have been about solving problems and building things from ideas. And so, I think that has enabled me to see the true potential. And now I am just sort of trying to join the forces to figure out how to make this really doable. Because at the end of the day, I'm a nurse. And, I know all the other nurses. You were saying earlier how tough nurses can be. If it's not easy, if it's not workable, if it's not feasible, they're not going to do it. So it's my job, I see it as my job to figure out how to make this as completely doable as possible. And it's, and we're going to talk about challenges in a little bit, but anyway.
So, Dr. Lang, how do you make this possible? What's your background? What's your origin story for MedXR?
I don't have an origin story like Amanda here. Mine's a lot more boring. It started when I was in medical school. I attended Case Western for med school. And it was during that time, Cleveland Clinic Case Western had a collaboration with Microsoft. So that's when the HoloLens was actually being developed. And so because of the relationship between the hospital and Microsoft, they started working together to see if they can bring this technology for medical education. And at the time, they developed a medical education tool called Holo Anatomy. Now I think it goes by a different name, but essentially it's trying to replace cadaveric dissection and cadaver for anatomy education and replacing it with XR. One of the reasons is, cadavers are, it's difficult to come by. It's the upkeep is very expensive. You need special facility to actually keep them. And the other thing is that you can't really make mistakes on cadavers, right? Like if you cut something and it's cut, you can't do it again. You can't try it again. So they saw the possibility of using VR to allow students to have training at any time, at home, asynchronously, but also being able to repeat simulations over and over again without having to worry about making mistakes. So that's when I was first exposed to it. And I had a mentor back at Cleveland Clinic as well, who's an interventional radiologist, Dr. Martin, and he's in the XR space right now as well. And with that, I took with me as I came here to Boston for residency. And I met my co-founders for the lab, Dr. Raul Uppet and Eleni Belsa, when we created the MXR lab. Number one, to create an infrastructure or space where people who are interested in this technology can come together, share information, develop technology, validate it, and then implement it across a healthcare system. So that's how I came to be involved in XR.
So this is fascinating. It's so interesting because, if I were to kind of paraphrase, I mean, Min, you got into XR because you kind of grew up with it, like professionally, educationally. Like you got exposed to it in your training. Amanda, you got into XR because you had a problem to solve, both for your patient, but also you saw it in something that you could have benefited from. So lived experience. Jeff, you came into XR just because, it sounds like you were just early, like before like you just like gadgets and you're a technologist by training. And I came into XR because, frankly, my boss told me I had to do it, and I'm a big nerd. And but I think the big kind of commonality is that there's so many pathways into this field. There's so many pathways. So we have our origin stories now. Now the question is, what are you all doing in XR? So I'm just going to start with you, Min. You kind of gave a little sneak peek about the MGB XR lab. So tell us more. What are you guys doing?
Yeah, we're working on a couple of fronts. I'll start with collaboration we're developing. Actually, Steve's in attendance, so I'll start with that. There are other groups in innovation in XR, MedVR being one of them. And that was recently, there was a hackathon about less than a year ago. A lot of projects came out of it, for the simulation space, surgical planning. So we're working with them closely on developing some of the projects that we grew out of that program. Other people that we collaborate with in our lab, we collaborate with industry as well. I think a key thing about MXR research is that funding is tight, is very limited. There's not a lot of places to get just funding for research. So we do work closely with both industry groups and startups as well, so we can actually get the technology for cheap or for free, and then we can sort of validate it. A company called Augment, we're working with them to look at data intake, behavior assessments. And within our lab, we're developing tools for medical education. So Dr. Raul Uppet created virtual reality liver biopsy training that's being implemented and tested across MGB for residency. So again, the idea for medical training is one of our main focuses is that, first rule for medicine is do no harm. But for training, how do you really practice on patients if you don't know what you're doing, right? So there's always a chance of harming the patients. So we're looking at ways that can really not replace, but really supplement or get the residents or fellows to a higher level before they touch a patient. And so that way there's less harm to the patient when they're actually, doing the training during residency and fellowship. And lastly, we're also looking, Eleni is also leading this too, we're looking at patient education. I think that's a piece that a lot of people don't focus on in the XR space. You're thinking about how are we going to make, nurses, physicians, everyone else to do better at their job for surgical planning, but the patient piece is missing, right? So we're also looking at ways that can teach patients, educate them on the procedures that are upcoming and what that entails. So allowing them to better understand their treatment, their surgery, and reduce their anxiety and increase compliance.
That's really exciting. Amanda, what are you doing in XR?
What am I doing? Well, so the next part of my journey, I decided that I was going to bring this to patient care. That was what I was like, okay. So I went to my manager. I came to her with the idea, and she was very supportive, which I just loved. So I started doing the work. I started doing the research, and I was just going to do it. So one night after work, I stopped somewhere, I got myself some dinner, and I was chit-chatting with this couple. And it turned out the woman was a Brigham nurse of 40 years, had worked on my clinical trials floor, was one of the first nurses to do a stem cell transplant. She was now one of the compliance consultants. And I mean, what were the odds of me sitting next to this woman at this bar? And she said, Amanda, you have to do this. She said, but I have one piece of advice for you. You're doing enough work to get your doctorate. And I was like, oh my God. But I hit pause. I applied with this project as my scholarly practice project idea, and now I will, I'll be defending in May. Anyway, but from there, and the goal, once I started doing the research, I learned that this wasn't just a way for patients to escape the hospital room. It was actually like a legitimate therapeutic tool to help patients with symptom management. And it's not only one symptom, it's not only pain, it's not only anxiety, it's quality of life, it's palliative care stuff. It can help a patient from the beginning of a diagnosis and move with them all the way to end of life care. So then I keep moving forward. IRB is no joke, especially when it comes to patients. And yet, something was bugging me. I think I went to VMed last year. It was my first ever virtual, XR conference. And there was a talk at the end of it that talked about barriers. And the message from that talk, my takeaway was we needed to find champions. We needed to find people like myself. I consider myself a champion of this technology. So I said, wait a minute, I think I'm completely missing a step here. I think I need to ask other nurses how they feel about this. They've been listening to me long enough talk about it. So what I did was I hit pause on the patient part of it, because implementation science says it's very important to have buy-in. So I hired a film crew, and I created a video about why nurses should care. I talked about, Mark helped me with the content. I talked about what it was. I talked about how it works. I talked about the evidence that I have found. I showed what an intervention would look like for a nurse. I likened it to a nebulizer treatment. Sort of, there's setup, but then you can walk away for 10 minutes and let them have their experience. And then I talked about why nurses care. And I just finished a study where I had for oncology nurses, and I looked at their knowledge gains. We started with really no knowledge. Nobody knew about it. Only 83% of them had ever tried VR. And the knowledge, I got a ceiling effect, they learned a lot. And then the next thing I looked at was their feasibility, acceptability, and how they felt it was appropriate for their patient population. And overwhelmingly, they loved it. Administrators, oddly, loved it the most. I was kind of expecting it to be opposite. So that was exciting, Now and even from that experience, I could see who really was excited about it. So I kind of, in my mind, have my champions in mind of who can help me. So next steps are twofold. One, I'm going to follow up with that oncology inpatient project, and I'm going to pick one unit. First, I had 13 units agree to do it with me, and now I'm only going to do one. I'm going to zero in. And hopefully we can figure out a way to successfully implement something like that on that floor, and then broaden it. And then two, I'm going to take that nursing study that I just finished, and I made the video purposely generalizable, so it could be not just oncology, it can go anywhere. It's for all nurses, inpatient nurses. And I've got Brigham agreeing to let me look at all nurses, like all specialties. So those are my next steps.
That's awesome. Go ahead, Jeff.
Oh, I just wanted to make a couple of points based on what you were saying. ICU delirium is a thing. You can Google it.
Oh, yeah.
Your mind is a story that is telling itself to itself, and its canvas is your environment. And that environment are the spaces and the people that you interact with. And without enough of that, your mind literally begins to dissolve. And that's exactly what's happening, when you're trapped in a tiny room.
Amanda, I think what you're doing is pretty incredible, because you're really setting not only an intervention to see how this works within a unit, which I'd love to actually learn more if you're willing to share some of the details. But you're also kind of looking at the sentiment of your colleagues, the deployers, the carers, the caregivers of this. And both of those pieces are so critically important. When we think about this technology actually being deployed, as when we think about AMXRA, the third kind of big goal of the organization is the actual adoption of these tools. Well, you need to have a willing party to do it, and you have to make sure that it works, right? Like it's effective. You're doing both, which is really incredible. I would love to learn though, just before we get to Jeff, your work at Children's, can you share a little bit about what your intervention is going to be in the unit?
Well, right now I'm sort of in the process of selecting applications, and my goal is to really, I feel like it's a little bit of a repetitive study in that people have already proved that this works in other places, but I need to do it at my hospital to show this hospital that it works. So the goal is really to test for pain and anxiety, pre and post an intervention. And it would just be, I've learned, at first I thought it was going to be a longer intervention, but I've learned that sort of 10 minutes is an ideal length of time for someone, 7 to 10. So that's the plan. I am looking for applications. Getting applications into a hospital isn't the easiest thing ever because you have to be very thoughtful about patient privacy and how much data these applications are collecting. You have to go through a special committee to have the architecture analyzed and approved. And, so these are the steps I'm taking right now. And then also, and I think usability is something I want to talk about a little bit further into the talk.
Yeah.
But I think simplifying it down to one unit and sort of trying to really perfect it there is going to be key. So.
I think that it's so fascinating. I mean, the field of medical extended reality in every proto form, it has a multi-decades long. One could say the early '90s, early '80s. I think Snow World was early '90s. So 30 plus years, and yet we are still, I would still say, very much in this early foundational stage. And some of these kind of opportunities are still there to really set the stage, and particularly with new platforms like Journal of Medical Extended Reality, be able to publish in a place where I hope more people can see it as just like a pillar of this stuff works, and it's not just in one specialty, one area, but just the technology works. With that being said, Dr. Jacobson,
Yeah.
what are you doing?
I'm not a real doctor. I'm an engineer.
Actually, I think you are.
I have a PhD.
Yeah, that's actually a real doctor.
That's an actual doctor, just FYI.
But my name tag has to have PhD, so in the hospital, so nobody tries to get me to save them. The through line for education in VR for medicine or really anything is simulation, right? You're creating a representation of a thing so you can learn about the thing. And the group that I work in, Immersive Design Systems, I said the name again, is we have the mannequins, the rubber babies. We do these live action simulations. And we are request driven. So a doctor or a nurse educator will say, I need to teach my people this. And particularly with the nurse educators, they're saying, we need to train our nurses, and there just isn't the resources to train them on certain things with all live action sims. So we have a fleet of about 40 headsets, mostly Quests. We're still using the HoloLens this year for pharmacy of all places. And we have about a half a dozen simulations that we're using for training on a regular basis. One category is a game-like simulation that's very much like a mannequin sim. You have a situation, a patient, you have one or two, or you can even have three or more humans that are in the environment. You might have a bot or two, and you solve the problem, save the patient. The next category is augmented reality, where we have physical props. We're doing this with the pharmacy. We create an illusionary workspace that they can interact with in a very simple way. There are certain steps they have to do, because if things aren't clean, people die. That's what my motto in the hospital. And then they have to create syringes in a safe manner. The next category is 360 photosphere-based experiences, which you can interact with from a headset, but most people just use an iPad. And those are great for basic knowledge, like what a space looks like, where things are. I'm going to date myself here. It's multimedia, with hot links. And then I guess the fourth category are the weird stuff, where we have one where we're going to simulate. We have a simulator where you have a mannequin and a probe's going into the mannequin, and there's actually a camera on the end of the probe, and you see stuff in the mannequin. Well, we're going to replace that interior view with a virtual view, and then we can do all sorts of things. And then we have something for the nurses that hand instruments to the doctors during a surgery, right? Very highly skilled position. You have to read the surgical field, you have to know the sequence, and you have to be organized. And we have a little iPad app. Once you finish that, you graduate to VR.
So if I were to summarize, it sounds like your group really has specialized in simulation as a service for the organization.
That's exactly what we do.
How much of it, and when you decide, I'm assuming you internally, once you get the specifications and the requirements, you make a decision on best technology to leverage and what have you.
Yes. Absolutely.
What's your breakdown on VR versus AR versus 180, 360 video, and do you build it all internally?
I was going to ask the same question.
Okay. Choice of media. We first decide who needs to learn, what do they need to learn, how are they learning it now? If we create what's the gap, right? What drove the educator to us? Can we fill the gap with a simulation-based training experience? What are the props? What are the actions needed? And then only then do we decide what the media is going to be, right? A VR simulation works fundamentally the same way a physical one does. You just can have different props. The virtual patient can do all sorts of things a mannequin can't do. On the other hand, you can't touch it, but you can touch the mannequin, etc. Your second question.
Well, so what's the breakdown? How many projects are you doing that are VR fully versus 360 video versus XR, AR?
It's let's see. I'd say the AR is about 20-30%. No, yeah, it's about 30%. The 360s is about 20, and the rest is VR.
Wow.
Yeah, just because AR is a harder technical problem. You asked a different question. It was really good, and I can't remember it.
It was about a full stack. You guys build it all internally.
Oh, internally. Okay. Medical schools have a huge advantage over us in terms of adopting technology. The students are learning the basics. So a company can make all these modules, and a medical school can assign it to 100 students, amortize the cost, and they're off and running. We have to build things in-house, or at least modify them in-house, because every department has different process and procedures, and for very good reason. Some of it is arbitrary, like where is the equipment in the cabinets? In a department, that has to be standardized, so the nurse can just go and grab whatever they need. Well, then we have to modify a scenario. So for the last few years, we've been using special purpose medical training authoring platforms. We do not endorse any specific product. We have used, and there's probably 100 out there. The ones we did use were UBSim and Oxford Medical Simulation. And we are now spent the last year learning Unity and a narrative scripting environment. And there's a lot of those for the game industry. There's a few for the training industry. One is education at XR, and another is motive. We do not endorse these or anything.
That's duly noted. I'm aware of the time. I have one final question that I'd like to open it up for the audience. This is going to be a twofer. So, Dr. Lang, what are you most excited about in XR, for XR in general or medical XR, and what's your biggest challenge that you see?
Maybe I'll reverse the answer to the question because I think it comes more naturally that way. But the challenge, to kind of write off what Jeff was saying, is in the simulation space, nobody has time to create very specific simulations for a specific process. There's hundreds of thousands of possible combinations. And creating those scenarios for us when we're thinking about simulation is very time consuming. So you tend to look at products that already has a big library that you can already utilize. But then the piece of solution that I'm very excited about is obviously AI. Right? There's a lot of companies with generative AI abilities that you can take your foundational library, but make different combinations, create different scenarios within minutes, allowing people who don't know Unity to use prompt engineering to actually create relatively good simulation training that can be used right off the bat. But beyond that, I think VR, same with patient, what I've seen for patient treatment for therapies. There's a lot of products out there, but they have a library of beaches, mountaintop, whatever scenario. But again, every person is different. My happy place might not be your happy place. To create something that's very unique for patients, very unique simulation, I think this generative AI piece is really going to be a key piece to allow people to create personalized simulation, personalized treatment, and that's going to be more accepted and adopted in patients because, again, this is unique for them, right? So, but another challenge that comes with it is how do you test it? So every single scenario, Amanda's going to be testing all of these solutions. Everybody's going to be receiving some sort of different therapy. Their responses are going to be different, and their reactions are going to be different. So that leads to additional challenges that we'll have to conduct, additional research, hopefully submitting to, JMed XR for publication. But the last piece I'll add for challenge that I really want to address, if anybody is interested in going to the XR healthcare space, is trying to get the hospital research, admin, and leadership to have buy-in from the XR space. Right? The IRB is not really familiar with the cleaning protocols, safety of patient transmission of data, hardware. They're afraid of Meta and Apple stealing user information. So we really have to come together as a community to create a standard or guidelines that can tell these hospitals that this is going to be safe. This is the protocols we're following. So it's going to be much faster to get IRB approval and clinical implementation. But that requires buy-in, not just from the leadership I mentioned, but also the developers, the engineers, the clinicians to champion, the standardization and these messages that will be hopefully able to convince the hospital systems and admins to accept it.
If only there was a interdisciplinary medical society that could
That's what was great at MXRA, part of the reason, right? Yeah.
Amanda, same question. What are you most excited about? What's a big barrier? And also actually a rider to Dr. Lang's question, how did you convince your leadership to let you do the thing? And you navigated the research kind of pathway. How was that?
I have a knack for putting my foot indoors. These are good questions. So challenges, I think you touched on a few of them, right? Like this whole idea of standardized protocol, it doesn't exist. I mean, the words Wild West have been actually written about, how VR is, and maybe that was 5 or so years ago, but it does feel like maybe as a community we need to come together a little bit and make some decisions. One of the responses that I got from, I had asked an open-ended question, and one of the nurses was just asking about patient selection, and so I think that could be a great place to start. I have a dream of creating, for Epic or any electronic medical record, a checklist. Just like people would be admitted, and you just automatically do a checklist, just like we do the determinants of social health or, any of these things. So
A checklist for VR, like acceptability, or?
Yeah, like what patients qualify, what patients don't qualify.
Got it.
Is there a standard? I mean, are there things we know for sure? We know people that have a history of seizures probably shouldn't try it. We know people maybe a history with motion sickness probably shouldn't try it, although they actually are using VR to help people with motion sickness on boats now. So, just let's decide who can and who can't do it, and maybe we come up with some kind of global checklist that we can agree on. Anyway, but there's so many different types of headsets and stuff. For me right now, the main challenge with my patient project is really finding the applications that will work, finding the applications that are doable for the hospital, where they're not collecting too much information about patients. The usability piece. I don't want to get a patient to agree to try this and then get to them and have something, that's not working. Oh wait, you can't see it. I have to really think through it so that it is doable, so I'm sort of looking into ways to mirror the headset onto a tablet or a laptop to make sure that we can set it up maybe for the patient. I don't have to rely on them. There's all these little details, that I keep coming up with that I need to figure out before I get it to patients. So I think those are my challenges. What am I excited about? I mean, I'm excited to be a part of this. I just believe in this technology so much. I went to this VR conference last year, VMed conference in LA, and I was walking around, and I just felt like I was surrounded by all these super smart people, and I'm thinking, what am I doing here? And I realized, I think my part in all of this is to figure out this implementation piece, to help get all of this amazing research that all of these people have done, and just how do we get it to people, to patients? How do we help patients with it? And so as far as navigating leadership and stuff, I mean, I think it's a good idea. And I think when I talk to people, that's the first thing I say. And I have an argument for why it's a good idea, So, and like I said, administration was, rated this the highest. Who knew? So they're excited about it at Brigham. They want me to scale this. And I am just hopeful that I'm going to be able to not only contribute here in Boston, but contribute on a larger scale, so that we can really get this rolled out.
Truly, boots on the ground champion. That's what I took away from your experience so far is it's so important to find the champions. Dr. Jacobson, you get last word. Most excited, biggest challenge.
Most exciting for me,
Yeah, MedXR, XR.
I am super excited about this new software, which will allow us to script interesting scenarios and flexibly change them. And I'm really excited about using AI to start vibe coding them exactly as everyone's been saying here. So
Vibe coding is such a an amazing kind of opportunity. It's truly, we were just talking about this, it's like the 3D printer for software, and with that, it has all the implications, right? You could make a lot of garbage with a 3D printer, but if you use it well, you can make something nice.
I'm looking forward to those disasters you get with every new technology.
Correct. Challenge. Any challenge? Or no comment?
Well, absolutely. There aren't enough hours in the day. You know, we're trying to. The more successful we are, the more time we spend delivering the simulations we've already made, so we have less time to actually make new ones. So and of course, we need to grow the team, but we can't just do it like that. So my colleague, the other half of the team, we hired her as an intern. Then we hired her back as an intern. Then we created a job for her because she was awesome, Angelina Gu. And we hope to do that again soon.
Excellent. Well, we have a couple more minutes, so I'm going to open up for questions. Any questions? Oh my gosh, okay. So hold on, Jenny's going to do it. All right. It's up to you, Jenny. Jenny's the boss. Yeah.
Is that okay? Yeah, cool. I'm Mia Zhang, designer, works for healthcare. I work with provider, patient, care team member in my daily work. My question is around adoption. I think sometimes the leadership may give us green light, they opt into alpha. Now the bottom line become how we can drive adoption into individual providers. I'm just curious, for those providers who are more cautious about new technology, what have you tried so far to help them see the value of XR and drive adoption from them? Thank you.
So the question was for adoption, especially for people who are maybe providers who may be a little bit more cautious or skeptical, what are the opportunities or what have we tried in the past, like to actually do it? Yeah.
I can take this first, take a jab at it. Two things that come to mind. First is healthcare people are very ingrained in what they already do and very ingrained in the tradition. So with any new technology or XR product that you're coming in, you need to see how it's going to fit into the current workflow. So if it's going to take an additional 10 minutes away from the provider to do something, or require another piece of integration that's going to take a few months to do, that's probably going to get shut down. So you have to find a way that's going to be easily implemented and it fits into the current workflow as efficiently as possible to convince these providers to actually use this technology. And number two, I think, is also the economics piece. So I know there's a lot of research that's being done for usability, perception, surveys and stuff, but there's not a lot of like actual economic studies that shows how much money are you actually saving, right? If you can demonstrate that this product is going to save you X amount of time per patient, and per patient you're saving $50, that comes out to whatever $1,000 a day and et cetera, right? That's a quantifiable benefit for the practice that you're offering. So I think those two pieces you start out, number one is making sure that you're not adding additional work. And second one, you're actually adding value, which is in terms of either time or reducing burnout or adding actual financial or monetary benefit for the practice.
I absolutely agree with that. Sorry.
Oh, no.
I totally agree with that. Also, if your application can provide something that isn't available any other way, like your example of taking patients out of the room virtually, there's no other way to do that.
Yeah, well, I was going to add, for people who are hesitant or skeptical, I think the goal should be to find the people that are excited and through them show that it works. I think and then the skeptic will see, okay, maybe I should give this a shot. So at least that's how I'm going to approach it. If I've had nurses who are maybe a little hesitant about trying it, there are other nurses who are equally super excited. And I think that if we can partner with the excited, acceptable people first and just let's just get down to it. And at the end of the day, it's going to be in the numbers. The research is going to show if it works or if it doesn't work. And I think then they'll latch onto it. I do agree with workflow. I think workflow is an issue for all healthcare workers. There are so many patients and you just have so much time. So anyway, that's my 2 cents.
I think that's spot on. I mean, my sense is, even though we're in almost nearing probably a decade of this epoch of accessible XR headsets, right, for the masses and whatnot, it's still, at least in the medical side, I would still think of it as an emerging technology. And, I think the principle should be one of kind of natural planes, right? You can spend a lot of time and effort trying to convince someone who's just never going to buy in to do it, or you can try and just refine the process for the early adopters and try and make it good. And then, I think to Jeff's point, look for the places where it's essential and then provide something that truly is incredible.
And if you find people who are excited about it and, maybe there's a quirk or something isn't working, they're gonna want to help you figure it out. They're gonna want to help you streamline that process, to your point, to refine it. And then, you kind of get it to a place where it's super workable.
All right, next question.
Okay, at the conference, there's been one topic that hasn't been touched upon, I think would apply a lot to Amanda's thing, and that's gamification. So we're talking about XR and all that, despite whatever happened with Apple Vision Pro. And a lot of it, some of it gets into entertainment. We talk about the interaction part, but the gamification, let's say you had a cancer patient, and it would have to be a separate, a subset of a cancer patient. And you could take them and they could see where their cancer was. I mean, that's their sole interest. Where is it? What's going on? What do the drugs do? How am I fighting this thing called the cancer cell? And I'm pretty sure if you went into the literature, you'd find a lot of examples where mental attitude, there's the type C cancer patient, for example, and so on. You'd find that the mental attitude could have, not deterministic, but could have a high correlation to the outcome of the disease. If someone could somehow envision fighting the cancer cell, I mean, what I'm saying might sound a little bit way off, but the gamification of XR, where you're now interacting and you're getting an education about what your disease is all about, not for every patient, but for some, and they could see where they're winning, where they're losing. This is doing that. We're now going to introduce this new therapeutic. It would make them much more of a participant, and they'd be able to, in a gamification sense, fight the cancer.
Yep.
So, okay, if you guys follow me for long enough, you'll learn that I am an idea person. And this touches on one of my latest we were talking about this, right? Being able to take scans and help three-dimensionalize them so that we could show patients, let's just say new cancer diagnosis. Where's the tumor? I had a tumor. I don't think I ever saw it. I saw a picture of it maybe just on a scan, and I read it on the paper, but I never had it visualized. So I do think that the power of the mind to fight these things, like you said, it really is. I do think that there is so much room for what you're talking about. And, more to the point, there are actually games where people can shoot their tumor I mean, I think that would be so fun. I think patients would really get into it, And then I was just pitching the idea to another patient whose daughter is going through therapy, and I was telling her about how it can be relaxing, and she looked at me and she's like, oh my God, I don't think my daughter could have relaxed. She had so much steroids pumped into her for the chemo. And I said, okay, well then I have like a food fight game for her. So there is I completely agree with you. I think visualization is huge. And I don't know. Well, yes, gamification, but for me, like it's about being able to visualize, like you said, you kind of so that it's a different way of learning about your illness and about how much progress you're making or not making.
But also, it's kind of I would just say, to your point about the gamification, to see the mental kind of mind-body connection to some of these things. That's an interesting question. I think one of the frontier areas of MedXR as a field of, I think, medicine, I think we all feel that way in some way, is looking at these frontier areas where you really need the technology as the intervention to do the thing. And I would say that's like an interesting concept. So I didn't know that there were games where cancer patients can shoot their tumors. Maybe that's a therapy in some way, right? I don't know. And, maybe someone does that. And I hope they publish in the Journal of Medical Extended Reality or another journal dedicated to MedXR, because now there are more than one. And I'm just super proud that we were able to support that and start that.
Well, structurally, any training experience is a game. It might not be that much fun. It would help, but they're games.
So all training is a game. I want to be respectful of time. Do we have time? We have one more question. One more question. No, actually, Jeff is. Yeah.
So back in 2013, about that time frame, we were working with medical organizations. I worked in aerospace, spacecraft manufacturing at that time. There's many similarities. We had to protect the data. Medical has to protect the data. We had to work in clean rooms, and there's, similar situations for medical. A question for you: when you look at the KPIs, our KPIs, I think we're relatively simple. We save time with XR. We can do a 90% touch labor reduction. A day of delay on the spacecraft is $1 million cost per day. So we could measure those value props easily. When you talk about needing to scale and getting buy-in for adoption, what are I don't even know if the KPI is the right term to use, but what is
KPI?
The metrics that you would
Key performance
use to,
indicator?
Yeah, to measure value. What would be the equivalent that leaders would be interested in to bring in adoption and for that buy-in? Or if it's not that, is it a barrier that's preventing them from being willing to bring it in?
I'm going to provide the ultimate weasel word answer, which is it depends, right?
Right.
It really depends on the use case, I would say, it all truly. So, there are a few FDA cleared interventions using XR, and I would say the KPI is, the evidence base that their indication for FDA clearance, and then as the, distributor or the payer that's going to pay for it, they want to so there's a solution that is FDA cleared for chronic lower back pain. And ostensibly the KPI is the people that use this get benefit and potentially use less costly interventions in the future. And it's a win-win for everyone. I'm making this up, right? But I think it just depends on the use case, what the KPI would be.
Absolutely. In the hospital, for training, we have to train people to not make deadly mistakes, and those happen. But not even necessarily mistakes. You have to improve the performance of your people so your patient outcomes are better. And anything you spend on the training is totally worth it. Your real competition is the other interventions that also help. So, Yeah, like a physical sim versus your VR sim.
I do think it depends, but you said you're from the aerospace industry. For pilots, they have to hit a certain number of hours before they're allowed to, fly by themselves, right? Part of it is simulation training, but I think in healthcare we're a little different in that our medical surgical simulations are not as close to lifelike as for pilots, for spacecraft, and et cetera. Once we get to the level that the simulations are similar to what a real surgery would be, I do envision a future, maybe surgical program's going to say you need 100 hours on this program before you're allowed to actually go to the operating room and operate on a patient. But at this stage, the simulations is not good enough to be similar to it. It teaches you the steps, but you don't get the feedback, you don't get the dexterity treatment, so that, how can you can't really use that as an indicator. I guess the indication is we don't know exactly what number that is and how effective is going to make an individual resident better or not. And second, the training program is very different. So there are very general guidelines that you need to do this number of surgery, but there's no you need to be able to perform an appendectomy within 30 minutes. We don't have these sort of metrics to measure someone by. So it's really a kind of a inter-person assessment. So how this person started, and then treatment after training, how they have progressed. You can sort of measure that. But it's hard to compare between different individual and across institutions. So the KPI thing is sort of what Mark's saying, it sort of depends because it varies so much. But in treatment, I think we do have a relatively good metric for research, right? Because we know what the outcome is going to be and what placebo or conventional standardized treatment is with or without VR. There's around 109 or a little bit over 100 FDA cleared AR/VR products out there now. And for those, we do have comparisons. So there are KPIs that we can show to hospitals that, if you implement the solution, 20% of patients are less likely to X. And that would encourage or, get a clinical champion to advocate for that product in hospital care systems. Relief VR, from Applied VR, other companies like XR Health and stuff, they do have products that are actually in the market because they're able to demonstrate actual benefits for patients through clinical trials and clinical studies.
Thank you.
I want to say we are not simulating surgeries. We don't have the tech to really do it yet. We may get there, and there's a lot of very smart people working on it. Our training is all about teamwork, communication, solving the problem, process and procedure, and basic skills, basic knowledge.
And for me, just from the patient side or from a clinician side, if we could show that maybe patients took less opioids or took less benzos or, their patient experience, I think, is becoming a real thing now. I think hospitals care how patients feel about how they were cared for. And then, if we could shorten hospital stays, that's a real marker.
Well, it's been a heck of a journey. We somehow got to 309, which I believe we are potentially over. So with that, I want to thank you all for your time. And if you're interested, I think we're going to be around. We have a booth, so come on by. There's no tablecloth. Thank you all.
Thank you.